Hello and welcome to our final session of 6 sessions on Virtual Nursing 101 series. And so this time we're going to pull it all together and really take the highlights from the previous sessions and really talk about how to start, scale, and succeed your virtual nurse program. And I hope everyone goes away with some very practical ideas. Even in registrations, there were some good questions about, what's the best outcome that we should focus on to get going. I think that's a really good question, and that is something that we will be talking about for sure. Let's see, each session had some practical insights, and that's what we're going to be highlighting. So just to kind of set the tone, I'm going to talk about some market research that has been done recently. The AvaSure has commissioned some market research just to see where we're at in the healthcare community with virtual nursing. And this is definitely a concept that's not going away. It's not just trendy, it's gaining momentum and gaining it fast. So we commissioned a third-party market research in 2022, early 2022, and then again early 2023 to really get a feel for where we're at with virtual nursing. And if you can advance the slide, we can look at what has changed in just 1 year. That dark teal color is the research that we commissioned in 2022. And so that was about 100 leaders across the US talking about where they are thinking about virtual nursing. And back then, almost 80% were very interested or very interested in virtual nursing. But mostly on that planning, a little bit of piloting, and very few had implemented yet. And then we recently did market research again, collaborating with AONL and Jocelyn Insight. And this was a bigger market research, and there was almost 800 respondents, and that showed the momentum. You can see on the orange, the momentum is moving towards actually implementing. So people are moving from planning to piloting to implementing, and I'm very excited that this research, the whole summary of that market research that was done in collaboration with Jocelyn Insight and AONL will be published tomorrow by AONL, and it's called the AvaSure Virtual Nursing Insight Study. So you can kind of keep your eye out for that and find out a lot more of what we learned there. And those of you who might be aware of Jocelyn Insight, they do the market research for ANA, AONL, and the DAISY, just to name a few. I'm trying to think of the DAISY nonprofit organization, very supportive of them as well. So we love that. So when we did our first, one of our first few sessions, we asked a similar poll of the participants, and we got kind of that earlier outcome. So if you look at that poll, what we did earlier in the series, and our audience that was listening was kind of in alignment with that earlier thinking and then piloting and implementing. So now what we want to do is see where we are in August of 2023. So we're going to launch a poll and let our attendees reply right now and see if this has changed at all. So where are you on your virtual nursing journey? Are you in the conceptualizing and planning phase? Have you started a small pilot or into your pilot, or have you really implemented? And we'll say implemented is just beyond pilot. Doesn't mean that you've got your full implementation across the entire organization yet. Okay, give that a minute. And I will let our organizer decide when it's time to show us the results. Okay, Still, the most are still on conceptualizing, but growing number have actually started doing it. And I'm not surprised on that. And there's a lot of outcomes that are being published in various settings as well that help guide us and that we can learn from. And that's just one of the reasons to pull this together, is just to create a platform where we can all learn from each other. So during the series, we talked about two specific virtual nursing models. If you go to the next slide. So I forgot about this one. We also did a poll about just a little deeper dive of exactly where you are and what's kind of motivating you to attend these sessions or attend the session today. And so 34 was the highest answer. 34% said that virtual nursing was part of their strategic plan and they were on the team. 25% said they had started a virtual nursing program or will be starting a virtual nursing program and wanted to learn more. Some already had a program or were looking for the learning community. Many are AvaSure customers, and there's a really good adoption model to really start with virtual sitting, where there's a very proven and tangible ROI on one-to-one sitter reduction and reducing safety events, whether that's falls in adults or the behavioral issues in pediatric settings. And then there were some that were just kind of, I don't think it's on our strategic plan, but I'm very curious to learn more about it. So let's repeat this one too, and see towards the end of our series who's attending today and what is driving your interest. And there are limitations with GoToWebinar's polling, because you might want to, there's not an option to choose more than one. So this is not incredibly rigorous scientific research, but it just gives us a feeling of how people are coming today. Are you on the strategic planning team? Are you looking for building your learning community? Are you starting with sitting and virtual sitting and know that in the future virtual nursing will make sense, and how do you leverage the same platform? Okay. Oh, more people have virtual nursing on their strategic plan. And we know why. There's a nursing shortage that is not going away, must be addressed. We have to look at doing things in a new way. So there's even fewer that are saying that virtual nursing is not part of their strategic plan. So when we really look at the models of care, and I had kind of talked about that adoption model, we often see, we're in 1,000 hospitals, and we often see starting with virtual sitting to really establish that ROI and the benefits with that, freeing up your nursing assistants to support a new care delivery model. And then the other two types of virtual nursing models are the clinical resource virtual nurse and the expert oversight virtual nursing models. And that's what we kind of dove into on 2 sessions, and we'll talk about the highlights from those sessions. And if you could advance the slide, it kind of summarizes those virtual care models. So that expert oversight model it kind of has been traditionally talked about as like virtual ICU. During COVID, we saw that expand into isolation units, or units where there was a high patient acuity and the doors were closed, and you needed that virtual care in order to keep those patients safe and provide care to those patients. But that's kind of overseeing a cohort of patients virtually and really provide, maybe higher acuity patients, and that virtual nurse might have ICU skills and is looking at physiologic monitors and proactively intervening on specific patients. And that ratio might be very high, and we'll learn a little bit from UC Health in Colorado, where there are 4 virtual nurses covering almost 2,000 patients, and they're just really looking at the most acutely ill across the whole 12 hospital settings. And then the clinical resource type of virtual nurse is where it's more focused on med surg and that's episodic, and that virtual nurse is interacting with one patient at a time, often helping with admissions and discharges and patient and family education, and can really improve patient flow, can support the bedside nurses. And that's what we'll kind of start with, talking about what we learned on our session that we talked about, the clinical resource telenurse. So if you want to advance the slide, in that session, we talked with Laura Gartner, who is a director of clinical informatics at Jefferson Health, and Wade Batt, who is a patient services manager at UNC Health Rex. And they had this model where one virtual nurse is interacting with one patient at a time. So she's probably doing an admission or discharge on the first patient, and then using their electronic health record, whether that's Epic, and communicating with the bedside nurses and kind of teeing up the next discharge or patient education or the next admission that needs to happen, and moving from room to room using our system. And we learned some really great tidbits from Wade and Laura, and so I'm going to share some highlights. We first talked about admissions and how helpful it is for the virtual nurse to help with patient admissions. So let's play that little clip and hear what they learned.
Similar in the sense that we do more admissions than discharges. The admission paperwork getting done by the virtual nurse has been a huge satisfier. Even though it's an observation unit, they are doing all the same documentation that an inpatient nurse is doing. So there's a lot of questions for regulatory and things along those lines.
I think one of the other big benefits of us performing all those admissions is the amount of data that we can collect that in the long term ultimately helps our patients. We're not just getting the required documentation checkboxes, those highlighted yellow fields in Epic. We go top to bottom until every box is completed or the patient begs us to stop. It's enough. All those social determinants of health, the community care aspects of the admission, and that helps us start impacting throughput by preparing for discharge as it's happening. We're mentioning the bedside binders and, your anticipated discharge. I know you're only being admitted would be 2 days from now, setting the framing in the patient's mind to prepare for that discharge on the day they're admitted.
And I think we are seeing across the board that patient admission is really a great and easy place to start for a virtual nurse, and it might actually be the most welcomed by the bedside nurses as well, to get that help from them. And it's a really great way to kind of demonstrate the assistance that a virtual nurse can provide and gain buy-in from bedside nurses. And they think, wow, yeah, now I have all that information that I need for the patient. And I actually got to visit with some of the UNC Rex virtual nurses, and they were bragging about, amongst the 4 of us, we have 100 years of nursing experience, and they didn't want to get away from patient care and loved that continue to interact with patients and they're not interrupted. And so, like Wade was saying, they were able to do it just very thorough admission, which really sets everyone else up for success, having all the information they need about patients. And then we also got a really good practical tip on discharges from Wade, and I don't want to steal his thunder, so I'm going to have us roll that video as well during that session.
Being able to remove the mandatory printing of after visit summaries to hand out to patients. It saves us something like $18,000 a year in paper alone, not to mention all the back and forth and the cumulative time that we spend delivering paperwork that sometimes people aren't even going to look at it. It's going to float around in their car for a week, So now we can send that electronically through, we use my UNC chart, and the nurse can check a box saying that the patient consented to that, and then we move forward. Now, it's still optional to print that paperwork if the patient requests it.
So that was a big aha moment during that session, that you don't even have to actually print all that mess of papers to hand to patients, and that there is something within at least Epic, because I think that's what they use, that you can check and say that you did it electronically with the patient. So a lot of great tips on both admission and discharge during that session. And then the final clip is kind of about the patient experience. And across the board, anything I've read about virtual nursing or any presentation I've seen about it, very consistently positive impact on patient experience. And I think this anecdote helps understand why.
Good barometer for all of our virtual nurses was that they all said, I'm not sure about this, I'm going to miss the patients. I love talking to patients. And they get more of that. That's all they get to do. And they don't have the Vocera or the phone, the call bells. And not only do they love that, the patients, particularly when we're doing admission sessions in the ED, they really feel like the course of the progression of their hospital course is moving forward. Finally, I can talk to somebody. I have this question. I need to know this. When is this happening? And most of that we're able to figure out through the chart and help the patient navigate the pre-bed hospital setting in ED. So
something I hadn't really thought about before that time, but we do have one of our hospitals partners that is focused almost entirely doing admissions in the ED holding area, and how that impacts patient satisfaction, that they actually have the perception that they're not forgotten and that they're moving forward and their plan of care is beginning, even if there's some time that they are in the ED holding area. And then the not being interrupted, like, oh, my bedside nurse is really busy, but you're not busy. You're just here on the screen with only me, and I can really ask you those burning questions that I had that I didn't want to bother my nurse with, because they can visually see how busy their bedside nurses are. So we also did a poll on the types of tasks that is a good place to start. And we know that and we'll show that now, but from the poll that we just did, those on the line here, a lot are kind of in the conceptualizing and piloting phase, and there's a way to phase in and really patient admissions, and what Laura and Wayne Batt had talked about too, that admissions were a good, early, easy win for virtual nursing. I intuitively would think that you should start with discharges, because that's what you really need to discharge in order to make room for admissions. But it really depends on your own organization needs and where you think the biggest way to get buy-in from your bedside nurses. So the poll that we did earlier kind of reflected that as well. Both admissions and patient education and discharge, and patient education is of course embedded in everything. And I'm sure that none of those discharges occur without patient education. So that I think that those two kind of go hand in hand. And of course that even starts on admission. And even some scribing and intentional rounding is a great way also to impact your patient experience. So on the next slide, I'm going to show you aggregated data that paints a picture across 7 hospitals using the AvaSure Connect platform, which is designed for that med-surg virtual nurse admission, discharge, patient education, staff mentoring model. And on the x-axis, you see from 8 a.m. to 9 p.m. So admissions and discharges are really focused a lot during the day, especially if you're setting up a virtual nursing program and you're maybe not starting with 24/7 staffing, and maybe starting with staffing during the times when your needs are biggest for admissions and discharges. And it's not surprising for me to see that you know, that curve of the lighter green discharges happening starting in late morning into early afternoon, and then the discharge is happening so that you can make way for the admissions to come in, either from the emergency department or, you know, post-op as well. And of course admissions come in all the time, but especially an onslaught in the afternoons. And so you're able to look at this data is automatically captured within the AvaSure Connect. And so you can kind of trend your data and then match the staffing. And what I don't have, which I wish I did, was to know when would those admissions and discharges have happened on those care units if they didn't have a virtual nurse. And I suspect they would get pushed out later in the day because of how much is happening at the bedside in that late morning time when staff is short. You know, we know it's short. And this is only 7 hospitals. There was another one that I pulled out because it's only focused. We have one organization that is only focused on doing ED holding admissions. And that kind of goes from when that virtual nurse gets there to the end of her shift, and she's able to really kind of help, like Wade mentioned, that is really promotes patient satisfaction as well, because they feel like they're getting some momentum happening. And then the bedside, when they receive the patient, they have the information they need, whether that's their primary nurse or the hospitalist, and it just helps smooth that patient flow. And then we'll talk a little bit about what we learned on the expert oversight session, which we did in June with, and that's on the next slide. And on that session, we did an interview with Amy Hassel. She was just promoted to the chief nurse of the University of Colorado Health Virtual Health Center. So they have a virtual hospital, and because they have a virtual hospital, they have a chief nurse of their virtual hospital, and that's Amy Hassel. And then we also had Dr. Himali Patel, who's the Associate Chief Medical Officer for Inpatient Services, talking about their model of care, which is more of an expert oversight across, so that one expert virtual nurse is overseeing multiple patients. And I'm going to share a little clip from that session. They really impacted sepsis because in rapid response, because that mobile device is put in the room for every rapid response call across the 12 hospitals. And stays there for 6 hours. So the rapid response nurse is there and gone within the first 30, 45 minutes, but the virtual nurse really knows that this is a high risk patient that they're following up on. And then they respond to alerts for sepsis and deterioration from Epic and their own homegrown alerts, and really impacting their mortality and patient quality of care. So I'll let them tell their own story.
This is our most recent sepsis mortality for FY23. The last 2 months are extrapolated because we're not at the end of FY23, but based on current run rate, we're on track to have saved 347 more lives just for the improvement of this past year, to your point of we continuously iterate. So if you look at the top right, our mortality index went from 1.06 in FY22 and we're down to 0.92 as a system. We always try to quantify everything, and when we're doing especially for our staff, just what does that really mean for patients? Just, when you're a remote clinical command staff, it's sometimes hard to feel that connection. And even on the front lines, you feel like you're running around like, is this making a difference? And so really this work has saved, even just this past year, 347 more lives. And so that's, one more dad or mom or loved one that's walked out the door that we're just so proud of.
As we deploy the RRT, what we actually do is we bring in a camera so that the virtual ICU nurse is able to observe the patient during the RRT, but then actually even observe the patient 6 hours after the RRT is completed. And this is extremely important because we know our bedside nurses have competing priorities, right? They have other patients that they have to go and take care of. And so they're not always monitoring the patients continuously. And this allows us to really monitor the patients continuously. If I remember correctly, it took a few iterations. We actually did this without the camera first and wanted to be a little harder and less effective because we weren't able to engage that directly with our, not just the bedside team, but with our patients. And so eventually came to the conclusion that the camera really does make a difference. That's the goal, is to bring it back down to the why. It's about a patient's lives, and it's about the evolution of a clinical condition changing over time, and that we want to help you take care of your patients while you are in the operating room, while you are in a procedure, while you are in another patient's room taking care of that patient. And so it's a team effort there. And as we look at our data, right, we looked at our sepsis data, 347 lives. Well, if we look at mortality as a whole, it is 786 more lives saved this year. And I think that alone speaks to the impact of the program, that sharing of responsibilities and partnering with a centralized workforce at the VHC with a bedside team has made in our patients' lives.
Very powerful outcomes there. And we actually showed that at our company meeting, because it just makes us all emotional to think about what we're doing is really meaning someone is walking out the door from the hospital that otherwise would not have. And on this next slide here, UCL also quantified some of their other outcomes, and they have that same adoption model, starting with virtual sitting. So you'll see that on the left-hand side here. They call that safety view. And this is where their safety observer attendants keep patients safe, and they develop a personal relationship. And it says that 730 is the amount of times they're intervening in a 24-hour period with patients. And it's so personal that they even talk about that they've had 2 marriage proposals from from patients to the virtual safety attendants. So they felt so comforted and so connected that they were like, will you marry me? And 0 marriages have occurred yet, but I love that, just to demonstrate that it's not a robot and it's not depersonalized. They're really engaging and part of the care team and building relationships. And then on the right-hand side, it kind of talks about how they achieved that almost 800 lives saved per year with the virtual expert oversight nurse. So that is actually one of their virtual ICU nurses, and they use the Verify AvaSure application, where they're able to engage in the video. Dr. Himali Patel was talking about how important the video aspect is for building relationship with the patient and also with the bedside team that they're collaborating with, because that's all across Colorado. And they saved lives probably by decreasing code blue. So if you decrease cardiac arrest by 25 to 40%, then your survival is definitely going to go up, because we know that the outcomes after a code blue are really abysmal as far as getting back to the same quality of life and also just, survival. So that was a great session. And both those sessions, the one on the clinical resource, sort of admission discharge nurse, and the UC Health session are available on our YouTube channel if that's what you're kind of interested in learning more about. But those were some highlights. And then another big question then is, who do you hire as a virtual nurse, and how do you really find the right fit, and how key this role is, that nurse that's sitting there and is interacting with not only the care team but with patients in a virtual way. How do you make sure that you are identifying the right people and providing the right training? So that was another session that we had, and in that session, and we can probably go to the next slide now, was done with the CEO of the Med-Surg Nurses Certification Board. And I had the privilege to participate in their task force as a subject matter expert to design a virtual nurse professional certification board certification through the Academy of Medical Surgical Nurses. So we spent that task force spent 2 days, and it was a very rigorous process to identify the domains, skills, and knowledge needed for a virtual nurse. And from that, it's the rubric for the professional certification. And I believe that is coming out soon. There was a press release on that you could probably find very easily. And they are writing and testing their test questions right now. And they provide the CMS, the Certified Med-Surg Nurse Certification as well. And she shared on our session the rubric and the domains for a virtual a nurse. And I'm not going to go into detail on all of these domains, but a few highlights that we talked about was that quality and safety piece. They are overseeing and mentoring novice nurses and making sure that they've got to have a deep understanding of quality and safety. On the communication piece, it was about communicating with the patient, the family, the care team, and website manner. Like, how do you communicate in a different way when you're in a virtual setting? And things as simple as gaze angle and you know, like right now I'm looking towards the camera versus kind of looking over here and documenting, and just those little website manner things that you learn as a virtual nurse and may not learn in nursing school. And it's really a coaching and mentoring piece was extremely important. It tends to be that the virtual nurses really need to have experience that they can share and support novice nurses at the bedside. One of the other task force members was sharing that when they looked at data for the reasons that a bedside nurse would reach out to a virtual nurse, the #1 reason that they reached out to the virtual nurse was for emotional support. There was one bedside nurse that was in the middle of COVID, really high nurse to patient ratio and high acuity of her patients, and the virtual nurse was helping with labs, making calls, letting her know, help her prioritize. And at the end of the shift, the bedside nurse asked the virtual nurse, "Did I do a good job today?" And the virtual nurse was able to provide that reassurance. And, you know, that's where we were losing novice nurses, because they didn't have that resource and they just felt so isolated. And so that is key, the coaching and mentoring part. So there's more that you can find out about that. You can watch the session or go to the Academy Med-Surg Nurses to learn about this new certification. I'm very excited to be doing a podium presentation at their conference in the end of September. That their conference is in Las Vegas, September 21st through 23rd. And I'll be doing a podium presentation there alongside Matthew Hemphill from Holzer Health about how they use a woundostomy nurse virtually, and a diabetic educator and they are rural, and how they provide that nursing expertise to a rural critical access setting. And that makes the woundostomy nurse just able to do so much more. It helps their discharges on both sides. It helps patient satisfaction, because patients can have access to that expertise, but still be in a hospital closer to their home. So very excited about our collaboration with the Academy of Med-Surg Nurses. But I think the burning question is really around, and I think we had this question even on the registration, what are the KPIs and what are the outcomes and what's the business case? And I think answers are coming out quickly, and it is becoming revealed that there is a very strong value proposition for virtual nursing that even your CFO could like and understand. So let's take a little time. We did a whole session on building the business case, but I want to talk about some highlights from that, and even just like new information keeps coming out about outcomes that others are achieving with virtual nurse that really helps it fund itself. And so when we did polling question at that session, we asked, you know, what are your biggest, because, you know, reasons for or areas where you need impact from virtual nursing. And the top one was efficiencies and throughput. You know, that is, who has that pain of holding in the ED, or even, God forbid, holding in the PACU that really causes bottlenecks that are expensive, impacting revenue, impacting patient experience, impacting safety. And it's really clear that if you have a virtual nurse who can help with the discharge and then the admission, that you can unlock some of those bottlenecks. And then the RN staffing is huge, in the patient quality and satisfaction. So there are tangible outcomes on all of these areas. I think decreasing holding time on the front end and shortening dismissal time. So from the time the doctor's order is written for discharge till the patient's out the door, both those can be impacted by the virtual nurse. And then you improve your opportunity days if you can shorten your length of stay and be able to admit the next patient more efficiently. On the patient quality and safety, we just heard really powerfully about that from UC Health. Lives saved, codes prevented, and obviously that means transfers to ICU prevented. And there's a mountain of evidence on virtual sitting that safety events are prevented as well as falls, in keeping pediatric patients safe and preventing safety events, whether that's eating disorders or low to moderate risk suicidal patients. So patient safety in virtual care is really strong as well. But that middle one, I think, is the key. And so that is RN turnover. And I think it's a conservative number to say that one RN turnover costs about $52,000. So if you look at how many you have and just impacting that a few percentage points, decreasing your RN turnover is a very measurable financial outcome. And the NSI National Solutions has been very popular survey coming out every year now about the cost and the RN turnover and the vacancies. And they also pointed out that decreasing 20 agency nurses replacing 20 agency nurses will save an organization more than $3 million. So that RN staffing piece is something that you're like speaking your CFO language, that can really impact the bottom line. But I think what is sometimes hard to wrap your mind around is how does virtual nursing impact your turnover? How do you connect the dots between that and the agency? So I'm going to make an attempt to kind of visualize exactly how those are connected and how that can and how you can have that impact. So if you go to the next slide, this is the traditional care delivery model. It's just an example, a generic example, say from a 24-bed care unit. I would say maybe this is the intermediate, where the model is a nurse to patient ratio, regardless of acuity, regardless of the nurse's experience. You're just trying to hit this hard number, 1 to 4. For example, here, if you're lucky in that model, you have 2 nursing assistants and you're trying to manage these patients across the whole 24/7. But we know that the vacancy rate is very near 20%. So what does that mean? That means you don't have one of those nurses. So one of those nurses just gets pulled away and you're trying to manage with either a nurse short, or we could put a nurse back there with big dollar signs on that it's an agency nurse or it's overtime. And if it's overtime, it's causing burnout and probably impacting your turnover. So now you have a little short staffed, and then if you've got 24 patients, 1 or 2 of them is going to need a higher level of surveillance, and maybe they're really having some significant delirium after a hip replacement or something. So then you have to move one of your nursing assistants into a one-on-one. So what happens then you're even further stretched. And if you think of the flow of the day, say it is morning and shift change has happened. Now the nurses are giving the medications, doing physical assessments, and doing tasks within the scope of nursing practice. But you're down to 1 nursing assistant. So who is doing those tasks that are not within the scope of nursing practice, like setting up a patient to eat, or helping them go to the bathroom because the lab just woke them up, or ambulating with them, or getting them cleaned up. And so it's 9 or 10 o'clock in the morning, 11 o'clock, all this work is being done. and the nurse manager comes and says, we have patients holding in the emergency department. Can you please go in and spend 45 minutes to discharge one of your patients? And the bedside nurse is going to be like, I can't, you know. And so that's what's happening. And that's the reality that is just not sustainable anymore. So how I think a lot of forward-thinking nurse leaders, not just me, this is what's being published, is a different care delivery model that involves virtual to help do some of those tasks. And if we go to the next slide, it could look something like this. And of course, it just depends on your organization. And you work with your own unit-based shared governance to figure out what works for us. So this is the resources we have and how can we do this in a better way. So this is one example, and it is where there's a team with an RN and a nursing assistant. Sometimes it's an LPN, just depending on the geography and state laws and managing a higher group of patients, maybe 6, but they've got a team. So everybody is working at the top of their skill set in their training. And you're not getting, you're able to manage with, and this model would be 20% less RNs with a virtual nurse who is helping with that discharge while all the other activity is going on. And then don't worry, you know, it's stressful to discharge a patient and have an empty bed and then have that bed be clean. And you know, oh my goodness, I'm going to get an admission. But the virtual nurse says, hey, I got you. I'm going to also help you with your admission paperwork. So that's not going to be such a burden. So this is the model that we're really seeing come out that can then therefore have a measurable impact back on RN turnover and the ability to not be quite as dependent on agency nurses. And so I just have a sample on the next slide of how you could put that into a business case. But this is something that we love to work with our partners on the hospital side that's very customizable to you. Like, what is your current ratio? What is your pay rate? I kind of threw something in here based on the Bureau of Labor Statistics on the pay rate. And if you can just decrease turnover by at least 40%, what kind of impact can you have with that? And then if you have agency nurses or if you're paying overtime, then all of a sudden this gets a lot more dramatic. But it's not one size fits all, and so that's why we have clinical assessments, free clinical assessments that we love to do with nurses, that a nurse and a technical assessment that can come to your organization and just walk it through with you. Like, well, we have a terrible holding issue in the ED, or maybe we don't. We're a pediatric hospital and we're having different challenges with autistic children that are, kind of we're the last resort for them, but it's really, we're having trouble managing them, or whatever is your biggest challenge. We've probably seen it before, and we want to connect the dots to help people learn from each other and just really not only address the challenges, but really come through and improve and innovate and take nursing to a new level, and actually use this to make nursing even better for patients and more satisfying for nurses, and maybe keep some of those lovely experienced nurses who might have otherwise retired. So let me see if there are questions. I haven't had a lot. Somebody did, I'll open it up for questions. Please type them in. Somebody did ask about the ED only data, and so we don't share, we only share aggregated data, and probably if we have 6 or more hospitals contributing data before we share data. But I'm hoping that organization that's really focused on the ED holding area, we'll do a presentation soon. They're measuring their shortening ED holding time, as well as dismissal times, as well as even that backup into left without being seen in the waiting room of their emergency department when they're able to kind of shorten their ED holding and decrease the number of patients that they have in ED holding. There's another organization that is utilizing virtual nursing in their discharge lounge together with the discharge suite or discharge lounge, where patients are waiting for the ride and they're being kept kind of monitored. They're no longer in the bed. There's a nurse there. That nurse is also able to do some virtual discharges and help with that too. So a lot, and I talked about the woundostomy and diabetic nurse virtual nursing presentation that we're doing in Las Vegas next month. So many different ways to use virtual care to impact the quality of nursing. Okay, and then there's another question about what are those KPIs again? And the session that we did on the business case, we really dive deep in what the KPIs are to measure in efficiencies and throughput, nurse staffing, patient experience, patient quality, and how can you assign dollars to that, and where is there evidence that virtual nursing has impacted those. But just to summarize them again, it's dismissal time. I always start with discharge. Dismissal time, so that's a KPI, the time from the order is written until the patient's out the door. Decreasing holding time, that's kind of on the front end on the patient throughput. Patient experience, and that's really around communication with staff and understanding their discharge medications, and then improving the quality of care. We talked about that with sepsis and mortality and code blues and transfers to ICU, and then RN turnover and agency nurses. So those are some of the high level. We do, I think, have a kind of a document with a list of KPIs if people are interested in. There's so much out there about primary nursing, so yeah, there is a great article written by Sylvain Tepinier from Providence, who and it's in the Nursing Admin Quarterly, and he has a great summary. Primary nursing, team nursing, there are a few other models, and the virtual care supported kind of co-caring model, and that's a different skill mix, and that's what they've implemented, and they're seeing really great outcomes from that. So please send us an email and I can send you a link to that article that whoever is asking about primary nursing. So I'm old enough that when I first came out of nursing school, it was all about primary nursing, and I've met Marie Manthe, who is the kind of a living legend in nursing, and defined primary nursing. But I think we can take some of those wonderful concepts and adjust it for 2023. So great question. I think that is all the questions. And thank you for everyone who has participated, and very excited about our session next week with CHS, which is a large health system who has decreased their falls and are talking about how they're centralizing their virtual sitting across their whole health system. So their chief medical officer and their chief nursing officer for the system, Dr. Lynn Simon and Dr. Pam Rudisell, will be presenting with us next week, and welcome back for that. Thank you.